Good afternoon, everyone, and welcome to today's webinar. We're coming live from a very sunny corner of southeast London. Hope it's sunny with you too. My name's Richard Todd. I work for an organisation called Kaleidoscope, and over the next hour, we're going to be talking about multiple long-term conditions on behalf of the Multiple Long-Term Conditions Task Force, made up of the Richmond Group of Charities, Guy's and St Thomas's Charity, and the Royal College of GPs. So I think we're going to have a really interesting discussion. I've got an all-star panel with us today. We've got Amy and Lisa in the studio, and Becky joining us from Morpeth. I'm going to allow you to introduce yourselves. Amy.
Thanks, Rich. Hi, everybody. So my name's Amy Cole, and I'm a consultant working in health and care. And last year, I was really delighted to be able to work with the task force to help them explore and learn from all the great practice that's already going on the front line.
I'm Lisa Williams. Good afternoon, everybody. I'm the Senior Project Manager at the British Lung Foundation and have been working on a 5-year programme developing peer support networks for patients living with lung disease across the UK.
Yes, thank you. Can I check, what's that memo about wearing black? Have I come in the wrong thing? And Becky, thanks so much for joining us.
Hi, no problem. I'm Becky Haynes. I'm a GP in Gateshead. I'm a clinical lead for diabetes in Gateshead, an RCGP champion for person-centred care, and I work with Year of Care as a trainer and GP advisor. Becky,
thank you very much indeed. So, well, what are we going to be talking about over the next hour or so? Well, firstly, we sort of, as part of this work, we sort of asked frontline practitioners what they wanted, and they said what they'd really love is a really thick policy report written in the most dense, jargon-filled language possible, because that would help them deliver what they want to deliver. Or maybe not. Maybe that wasn't what they asked for. Instead, they said something really practical, a guidebook to assist them in how they think about multiple long-term conditions, which indeed, I think we can even brandish, Amy. Look at that. Fantastic.
Yeah, copyright here.
Copyright here. Fantastic. And hope people have managed to see copies of that prior to today, or if not, then to go away and have a look at it after today. So we're going to be talking through the guidebook today, and in particular, sort of focusing on 2 of the case studies included within it. So I'm really sorry if you've joined us today for a lot of abstract chat about stuff not really related to what goes on day to day for most people working in health and care. You've probably come to the wrong place. If you have joined for something really practical and helpful in terms of how you deliver care, then welcome. It's so lovely to have you with us, and thank you for that. So we'll be talking through the guidebook. We're talking particularly about a couple of those examples, but we'll also be talking about how the task force can further support you. And ahead of today's session, we set you some homework. We asked you a couple of questions about how you could see the task force helping you, and we'll be going through some of the answers to that later on. So lots to look forward to. I should say before we get going, you might be wondering why there's something which looks like a Victorian sweet jar sitting on our desk. This is our jargon swear jar, where I will ask my fellow panelists whether you're in the studio or if you're in Morpeth to donate. I'm afraid if we do get into jargon or unexplained acronyms, you will have to put money in the jar, with the egregious nature of the jargon being proportionate to the sum. So we'll see how we get on. But we're going to try to have a jargon-free session today. So thanks again for joining. And we're going to kick off, before we sort of go into a bit of detail about the guidebook, we're going to just kick off with a very quick poll, just to see who is joining us on the line today. So we're simply going to ask you, let's ask you one moment. Firstly, to say that there is, that you're going to hear presentations from us today, but we'd also love you to join in as well. So in a second, we'll ask you sort of where you're joining from. But before that, if you are wanting to ask questions as we go through, please do. And there's a range of ways to do that. So firstly, you can use the Ask Question feature on GoToWebinar, which will be there on your screens. You can email us. That email address is hello@coscopehealth.org.uk, or you can tweet. The hashtag there is multiple solutions. You've seen what we've done there. Multiple solutions is that Twitter hashtag, you can also put in, if you would like, the Twitter handles of our 3 constituent organisations for the task force, Richmond Group, RCGP and GSDT Charity. And just to say, if your computer decides to expire in the middle of our viewing today, fret not, we are recording today's session. You may well be watching it at a later point, and we'll be sharing the link later on. So we will now ask you just to share a bit about where you're joining today. So a very quick poll. So what kind of organisation / setting do you work in? You may work across various of these, but if you just want to pick one, so that could be primary care, so acute hospital, community, it could be within a BCSE organisation or local authority, or our wonderful catch-all title of other. So if you'd like to vote now, we'll give you 6 more seconds to do that. We're moving at a pace this afternoon. We should put bets on, shouldn't we? If in any way we wanted to endorse gambling, which we don't. But we'll see the results there. If we can close that now. Thank you very much. The results will pop up. The tension. Lovely, thank you. Well, what a nice mix. Well, I'm going to say we've got at least more than 0% from primary care, but Becky, we've got you on the line. So we've got but a nice mix there from hospital and community, VCSE or local authority, and tied with other. If you are from other, what I'll ask you to do, if it's okay, is if you just want to scroll in the question box, that little chat question box on GoToWebinar, where that other is, just so we know, that would be lovely. But great, thank you very much indeed for the diversity of people tuning in today. We are going to very quickly hear from Neil Tester, Director of the Richmond Group, just to set some of this work in context. So I think we're going to cue a short video of Neil explaining how this fits in.
Hello and welcome to this webinar to explore some of the brilliant case studies in the Multiple Conditions Guidebook. Welcome from me, Neil Tester. I'm Director of the Richmond Group of Charities, and I'm just introducing this webinar on behalf of our partners in the Task Force on Multiple Conditions. So that's a partnership between the Richmond Group, which brings together 14 of the national health and care charities, together with the Royal College of General Practitioners and the Guy's and St Thomas's charity. And we've been working together for a couple of years now, firstly to really understand the issues around multiple conditions, the experiences of people dealing with life with multiple conditions, and now moving into the issues that we're really keen to discuss with you today, what frontline professionals can do to help make simple but really positive, impactful changes to improve systems and processes and services and support in all kinds of different ways for people with those multiple conditions. It's a massive issue for people's lives. It really affects people's experiences and outcomes of the health and care system, but it goes much beyond that. It can get to the heart of your experience of your daily life. We've heard some really powerful stories in some of the previous ethnographic research we've done, which we published in our task force report, Just One Thing After Another, where a number of people very generously shared the minutiae of their daily lives, and you could really get a sense from that. Do go on our website and have a look at some of the videos and look at the report if you can. You get a real sense of what it's like, the grind of dealing with unconnected, disjointed services, so rarely being asked what matters to you, what's going on in your life, rather than being asked very narrow questions about individual treatments, individual medication, and missing out sometimes some of the really key things that could make a powerful difference to people. So with the help of our external advisory group, with people from a wide range of disciplines and backgrounds, we decided that the next step we should take was not to do more policy analysis, not to do more research at that point, but to try to identify some of the good practice and the really creative thinking that we knew was out there in all kinds of different organisations across the country, to try to identify the things that others could learn from, the things that would be really powerful to share, and to get a sense of any common themes that might be linking those successful steps forward. I'm really pleased to say we identified a good number of those, and we're able to bring some of the key ones together in our Multiple Conditions Guidebook. And that's what we're going to be discussing today, with some of the help, with help from some of the people who are behind case studies that we featured in the guidebook. The guidebook will take you through a wide range of situations, scenarios, but there are some powerful common themes that link the ethos behind them all. I'm going to let my colleague Amy talk a bit more about that in a moment. But finally, I just want to say thank you for taking time to take part in this conversation. Really hope you'll get some very practical thoughts out of it, but we really hope you'll share your experiences and your learning too. And please stay part of this conversation. We don't want the story to end with this webinar today. We want to carry on building the conversation, both through all sorts of professional networks and face-to-face opportunities, but also online. We're using the hashtag multiple solutions. Do share your thoughts, do react to this webinar, do tell us where you'd like this conversation to go next, because it really is all about how we can help people to unleash the creativity, the teamwork, and the different ways of thinking that can really transform the position for people with multiple conditions. So thank you and enjoy the webinar.
That was Neil Tester, Director of the Richmond Group. Thanks very much, Neil, for kicking off today's webinar. So I feel a personal sense of loss. I spent a decade working in policy, and unbelievably, this is not a policy report, but something more practical. Amy, I think you're going to introduce the guidebook and some of the particular focuses within it.
Brilliant, thank you. So as Neil said, the task force knew that there was a lot of good practice out there for people with multiple conditions, but to be honest, they struggled a bit to really find out some concrete details about who was doing what, where, why, how, when, what impact they were having. So they commissioned a targeted review of existing practice. And as part of that review, we looked at over 45 different examples, different case studies from around the country, and they were from different settings, with working with different people in different ways. And from those 45, we agreed with the task force to look at 10 in more detail. And a summary of those is available to look at on, I think, page 22 of the guidebook. So that will give you an overview of all 10. And obviously later on today we're going to hear from Lisa and Becky, who are going to talk about those two. But before we get into that, I thought it might just be helpful to pull out a little bit of the learning that we took from looking across all 10 of them. So as Neil said, we were able to identify some common themes, and I should say probably before then that actually overall there was some really good news, as in there's really good practice going on around there with people with multiple conditions, and that was a really positive thing. And obviously we were looking at 10 case studies, so it's not a huge number, and they're all unique in the way, in their local settings, the people they were working with, and the sort of geography and all of that. But actually we were able to spot quite easily some themes that seem to cut across all of them. And on the slide that's just about to come up, you'll see the 8 themes that we identified. So now I'm not going to run through all 8 of them now. You can read about them in the guidebook. We go into a bit more detail on each of them, but I just wanted to talk about a couple of them, or put a couple of them out near now that are perhaps relevant to the case studies that we've got here today. So one of them was this, the people like me, and this was really reflecting the idea that it's people with multiple conditions themselves that have perhaps the most, well, definitely the most insight as to what it's like to actually live with those multiple conditions. And so we found that a lot of the examples sort of built on that, either through working with people with multiple conditions in the design of the work that they were doing, or actually had people with multiple conditions delivering a lot of the work. And that's the case in the British Lung Foundation with their expert patients. Something else, so taking the long view, one thing that we found across all of the case studies was this is not quick fix work. This doesn't happen overnight. I think the minimum amount of time that any of these projects or programs or ways of working was set up was 5 years. And that was something that we thought was, you know, really important to draw out, because as I said, it's not a quick fix. And another one is this idea of time to talk, and that actually for people with multiple conditions, you know, it's quite complex having multiple conditions, and it can have all sorts of different impacts on your life, and some of that can be really difficult to explain in just a sort of 10-minute consultation. And I think nearly all of the case studies had sort of much longer than that, sort of built into the way they worked with people to really allow people that time to talk and to explain what was happening in their lives. Now, for those of you that work in health policy or are perhaps trying to deliver more person-centered care in your area or trying to integrate services, all of these themes will be quite familiar. I mean, a lot of them are sort of quite common sense, I think. And you know, we also saw that most of them really are reflected in the NHS long-term plan and their ambitions for the future of health and care delivery, which, you know, we saw as really good news. Now, obviously, for those of you that are on the front line, though, and those of us that sort of work in change and other stuff, you'll know that sometimes policy ambition, as great as it is, actually is very different from trying to implement practical change on the ground. So we also decided to look across the case studies from the perspective of, were there any common factors that, or common things that people had used, techniques to try and put stuff into place? And on the next slide, we're going to see 4 techniques of change that we drew from across the 10 case studies. Now, obviously, this is a complex area, and we set out in the guidebook some of the complexity around the challenge of multiple conditions. And, you know, what we sort of saw in a nutshell, what we see in a nutshell is that, you know, there's layers of things that interact. So you have all the social, environmental and economic influences, factors that influence people's health, one thing. You also then have sort of interaction between physical and mental health, different conditions and treatments. And then also you have sort of the way that health and care are traditionally set up, very much to focus on specialties, and the way that this all increases complexity if you have multiple conditions. But actually, in terms of trying to deliver practical change on the ground, we found that the complexity could actually be perhaps more of a help than a hindrance, because as we looked across the case studies, from whichever point they started at, whether it was dealing with people with a particular condition, or whether it was dealing with people from a particular age group or around a particular issue like employment, they always ended up having a lot of people that they were helping that had multiple conditions. And if you think about the sort of the scale of this challenge, so 1 in 4 adults in England lives with 2 or more long-term conditions, then that kind of makes sense. And in that regard, we sort of thought that although it's complex and it can feel overwhelming as to where to start as a frontline practitioner, actually there are many places to start. And even going beyond that, in some ways, it almost maybe doesn't matter where you start. It's actually just getting started and thinking about how you can work with people with multiple conditions that makes the difference. And we also saw that in many examples, it wasn't that there was a big revolution in the way that things were being done. It's quite small shifts in practice. So I'm sure, you know, I don't want to steal Becky's case study, but, you know, in Gateshead, one thing that they did was they moved the annual health check appointments to a patient's birthday month. They put the letter on a piece of yellow paper, and they sent test results ahead of time so that people could prepare for that. And, you know, those sort of quite small shifts sort of make a difference. Another technique, another factor that we saw was the idea of external support and how that can help. Now, we don't want to say that you can't do anything without external support, because obviously that's not true. But we did find that across all the case studies, they'd either sort of sought out expertise from a group like Year of Care or Nesta or an academic health science network, or they'd had some initial upfront funding from somewhere like one of the NHS funds to sort of try and help things get going initially. Then the sort of final thing that we saw was that actually, you know, this isn't an issue that is for healthcare professionals alone to try and solve. And actually we saw across the case studies that it was many different types of people that were leading the way. So, you know, in Luton, for example, it was exercise trainers. You know, in the Southwest Learning Disability case study, it's families and carers. And, you know, in the British Lung Foundation case study, it's expert patients themselves. So, you know, really, you know, the sort of technique, you know, think about involving others and how you widen the lens on some of this, we thought was quite helpful. Now, we were hoping by sort of setting out the practical details from the case studies, the themes, common themes across them, as well as some techniques for change, that we'd be able to help some other people on the front line to change their practice. And this really, the purpose of the guidebook was to give to frontline practitioners a bit of a sort of a guide, guidebook of tools so they can make some changes. So as well as the things I've just run through in the case studies, we do also have a summary in the guidebook of the previous research that Neil mentioned about how people with multiple conditions themselves adapt their lives. We also signpost in the document to lots of other research and lots of other people's tools to sort of try and save people time and effort from having to dig all that out themselves. And on the next slide, you'll see where this is the website for where all the resources are. We've also got the material in lots of different formats. So there's the actual guidebook itself. There's also some summary slides. We have an infographic. We have the standalone case studies in their own sort of document. We've also collected some practical resources from the case studies themselves. So we have things like job descriptions for key roles, referral forms, and that's all available on that website, so you can access it from there. So we'd just like to encourage people to go there and have a look.
Amy, thank you very much indeed. A fantastic start to our discussions today, and a huge amount in there. So just to repeat again, that I think people can go to that link, or even I think if people Google multiple conditions guidebook,
yeah,
it will probably be in the top 1,000 results you get back from Google. No, it should be right there at the top. So if you're yet to go through the guidebook in detail, please do seek it out. Lisa, we're going to come on in just 1 second, but I think before we do, a lovely slide, Amy, just in terms of those four different techniques for change. I wonder if we can just have that one back up. There we go. As a question back to you, joining, if that's okay. So all of you joining, wherever you are across the country, thinking about those 4 techniques for change. Do you have examples of where you've used those approaches? One, maybe more, in your local context. It might have worked brilliantly, and it's a story you want to share with us for something which we would all copy, or it actually might have been a bit trickier than you'd first hoped. But a bit of homework halfway through the webinar. If you've had experience of using any of those 4 techniques for change, if you just want to put it in the chat box on GoToWebinar, if that's not working for you, again, that email address, hello@kscopehealth.org.uk, or you can even tweet it, put it out on Twitter. That hashtag is multiple solutions. Use the ask question box. You can email us, but you tweet it out. But those 4 techniques, have you experienced of trying those? How did you get on? We'd love to hear, and we'll come back to those later on. I should say these are beautiful graphics as well. It's worth looking at the report just to sort of see pretty pictures.
It is, and the details of the graphic designer are in the report, and I'd like to give her a great shout out because she's fantastic. Yeah.
Do please find those details. Amy, thank you very much indeed. We're going to come back for questions later on, but please do send them through if you have them. Lisa, I think we're going to pass to you.
Okay.
You are one of the 10. We're not ranking the 10 today, are we, Amy? We're not saying.
No.
But the fact that you're here, Lisa,
I mean,
I'm not going to let people draw their own conclusions.
I'm not saying anything.
Lisa, I think you're going to talk us through your particular case.
Yeah, so I have worked for the last 3.5 years on our integrated Breathe Easy programme, delivering and implementing support groups nationwide. Have we got our slides
Let's get those slides.
bob through, if that's okay? If we can bob on to the next one, please. So the background to the integrated Breathe Easy programme is developing our network of existing Breathe Easy support groups that we already have. And the idea of these integrated Breathe Easy groups is to really embed these groups into respiratory care pathways, so that there's that connection between people who are living with a lung condition, the peer support sessions that are available to them, and local support systems from healthcare to support those groups. So the groups are developed on a basis of sustainability and are volunteer led, which is an absolute gem. Without the volunteers that support the groups and lead the groups, these groups really wouldn't be able to run. So they're very much rooted in the places of prevalence and need, and we identify where we should set up these new groups with, and in partnership with the patients themselves, the carers who are affected by supporting people with lung conditions, NHS services including primary and secondary care, pulmonary rehab services, and we really work closely together to be able to identify where there is an area of need and how we can best support those people living with a lung condition and being affected by a lung condition on a daily basis. The only way that this has worked so well is that patients and carers and anyone else affected by a lung condition have been so embedded within this process. So we work very, very closely together, which has been an absolute godsend. I think some of the themes that Amy mentioned earlier around sharing conversations, this really becomes apparent in some of the anecdotal feedback that we've had from patients and carers, that they've got a real sense of camaraderie, you know, from being with others. What we do know for people living with a lung condition is that it can be incredibly isolating, and knowing that there's somewhere to go where they can meet with others who are in a similar position to themselves, and it's a safe space. You know, if they do have a cough or they become quite breathless, that there's somebody there or there's other people there that can support them and help them along the way. We know that working so closely with local healthcare professionals at the groups, it really does enhance people's ability and capacity to self-manage. So that has a knock-on effect in terms of their use of their GP practice. With no disrespect to the GP practice services, you know, we want to keep people as best we can out of those sessions, and also reduce unplanned hospital admissions too. So we know that people really do enhance their skills. One of the things that Amy mentioned as well around widening the lens, it's that sort of multi-organisation input really. So at the group meetings, people hear from local pharmacies, they hear from respiratory nurses, they hear from consultants, lots and lots of different people, and it can be that real, you know, one little gem of information that really makes a big difference around enhancing inhaler technique, or, you know, just knowing how to use your inhaler correctly can make a massive difference and have such a big impact upon people's lives, a real light bulb moment. The challenges that we face, obviously working with people who have a respiratory condition, is that by nature of the beast they can be quite poorly at times, and this is where, you know, we really do value people's input in volunteering with the groups and in the groups. If we can move on to the next slide too, if that's okay. Oh,
back a couple of slides.
Yeah. So what we've also done is improved and enhanced people's access to activities. So the Breathe Easy groups meet on a monthly basis, but we combine some form of weekly activity as well, so that it maintains that social contact and really enhances people's connection to others. So the activities have included Tai Chi, singing for lung health sessions, walking groups, nothing too strenuous, but just gets people maintaining that continual contact, and that has been really life-changing for some people. You know, we've had feedback saying that the Breathe Easy groups and that connection really takes people to a different place. You know, people don't just want to be identified by their lung condition, that, you know, that they're a person with other interests themselves. So the group members have really developed their own social networks as well, you know, developing friendships and activities and trips and visits outside of the Breathe Easy groups.
Thank you very much indeed, and we'll come on to Becky in just a moment, who will say exactly about when we want people to go to GP practice and when we.
No disrespect, Becky.
Not at all, not at all.
But Lisa, before we move on, firstly a reminder: please do send through questions for all of our panelists as we go through. But one of the points Amy raised earlier was just the importance of picking somewhere to start.
Yeah.
And actually looking at sort of relatively small shifts in the power small shifts can make. Can you just talk us through a bit more, Lisa, just about where this came from? Where did it first? What did it first look like at the very beginning?
The integrated groups were piloted in Stoke-on-Trent a number of years ago, and this was about developing that link with patients who are experiencing and living with a lung condition and enhancing their contact with respiratory services, so that we know there's that two-way conversation. Patients can feed into how respiratory services are managed and developed, and also they can have a captive audience and encourage people to self-manage and develop their skills to be able to do that. So the pilot took place and was robustly evaluated by the University of Kent. And with that cohort, there was a 42% reduction in GP appointments related to their lung condition, and 57% reduction in unplanned hospital admissions related to their respiratory condition. So we're just about to repeat that evaluation now, 6-7 years on, with a new cohort of patients that we will be working with in Scotland, Wales and England.
Lovely. So all roads lead back to Stoke. Stoke the hotbed. Lovely. Thank you very much indeed, Lisa. Thank you very much. We'll move sharply on, but just once again to say, if people would like to send through questions, 3 ways you can do that. Use that Ask Question feature, email us hello@kscopehealth.org.uk, or use Twitter, #is multiple-solutions. Please do send comments and questions as we go. If you're joining us not live, if you're joining us from the future, so to speak, that Ask Question feature is going to be absent, but please, of course, do send us reflections on Twitter. We'll move straight on. Becky, thanks again so much for joining us, and you're going to talk us through one of the other case studies in the guidebook.
I am. Just to start with, so I don't get fined for using jargon, I'd like to just say that when I talk about Year of Care, they're an NHS organisation who have been set up to give expertise, support, training and implementation for care and support planning across organisations. That's what Year of Care is. And back into...
I don't know, Becky, if you use jargon and then just explain it. I think that still means you've used jargon.
Oh, no. I'll flick it 10 pp across you. So back in 2013, our CCG decided to rethink its approach to long-term condition management. Since then, the CCG have supported practices to use care and support planning for people with long-term conditions, and to do multi-morbidity reviews, focusing on what's important to the person and supporting self-management when appropriate. Some of the practicalities of the case are written in our case report, but today I thought I would talk through a patient journey within our system to make it really clear the work that we're doing at the moment. One of the benefits of care and support planning with the Year of Care approach is that the process involved is as suitable for a young person who has, say, type 1 diabetes and asthma, as it is for somebody older who has several long-term conditions and maybe complex social needs as well. So you have one system for practices which offers support throughout a lifetime for a person. In our CCG, a lot of the care and support planning is done by practice nurses and nurse practitioners, but I'm going to talk about a patient that I saw last week with her permission. Beryl is 82. She's widowed and lives alone. She gets home visits when she's unwell, but when she's well, she likes to try and get to the surgery, but she has to come via taxi, which is expensive for her. She has many conditions, including type 2 diabetes, high blood pressure, arthritis, thyroid problems, lung problems, including COPD, kidney disorders, and frailty. In our old system, before we changed, she would have been recalled to the practice probably 2 or 3 times a year for diabetic checks. She'd have been called in once or maybe twice a year for a lung check with a lung clinic. She may well have had a different appointment altogether for a medication review, and in those reviews we probably wouldn't have asked her about things like her arthritis. So she would have ended up through the year, even when she was feeling quite well, coming down multiple times. Under the new system that we do now, she's recalled round about her birthday month so that she and we know roughly when it's due every year. She gets an information gathering appointment with one of our healthcare assistants, and this is usually about 30 minutes, and it's where all the tests and tasks that need doing are done. So things like blood tests, blood pressure, foot checks, assessing for falls, that all gets done in that appointment. And the process can also be explained to people who perhaps are new to the practice. There's then a triage step within the practice where we look at the person's preferred doctor or nurse, what conditions they have, look at their results and their medication, and we decide who perhaps the best person would be for that next care and support planning conversation appointment. So if we go back to Beryl, she got a 30-minute appointment with me at the surgery in the early afternoon because that's the easiest time for her to get down. We send people preparation information 1 to 2 weeks before this appointment. And as Amy said earlier, this is on yellow paper, so it kind of stands out from the other medical posts people get. This has a space on the front to record what's important for that person at that time. There's also some agenda setting prompts that they can circle, things like low mood, finance, relationship problems. Inside, we send a copy of some of their results with a brief explanation of those and the previous year's results. And on the back, there's space for a plan, goal setting, action planning, and a review date. So Beryl came into her appointment and she brought her yellow form, and on there she had written that what was important for her is that she felt tired, lightheaded, and had breathing problems. None of those were new problems for her, but that's what was important to her at that point. She'd also written down that she wondered if she maybe had anemia or thyroid problems were back again. And on the agenda setting prompts, she'd circled hearing problems, pain, and future health. She also produced from her bag her do not resuscitate form, which she wanted us to update, and a note from her daughter because she'd looked at the results with her daughter and her daughter had some queries and had written those down for me. So in our 30 minutes, we had plenty of time to discuss these issues, go through them in more detail. I was able to reassure her that she was not anemic, but that her thyroid was underactive and that could definitely be causing some of her symptoms. Between us, we realised that she'd stopped one of her inhalers about a year previously because she didn't like the way it worked. So we discussed this and managed to offer a different inhaler that worked in a different way. And I asked the pharmacist locally to show her how to use it on her way out. We looked at all of her other medication, including a painkiller called amitriptyline, and we discussed that can cause tiredness and lightheadedness. And between us, we agreed that we would try reducing the dose of that. I had a look in her ears and they were blocked with wax, so we gave her some self-management advice about her ears to try and help her hearing. Her current goal when we went to goal setting was that she wanted to live until she was 90. So we had a little talk about that, and we updated her do not resuscitate form at her request, and I also scribbled a note to her daughter answering some of her questions as well. A couple of things she mentioned to me, I wondered if she was a bit lonely, so I started talking a bit about our link workers, sort of social prescribing, but she firmly told me about all her many visits every day from members of her family at different times of day, and she said that she didn't really want any further input for now, which was fine, but at least she knows it's there in the future. And I gave her the contact of our local Age UK Gateshead just for some financial queries that she had. I arranged to speak to her in 2 months to review those medication changes, but just by phone, and then she'll have a review in a year. So I think hopefully in listening to that, you'll see why as a healthcare professional, this just feels like a really satisfying way to work. It works better for us and better for the patient. And certainly in a recent survey in our CCG, 93% of patients who had had care and support planning felt fully able to talk about the things that were important to them, and 90% felt more involved in their health and well-being. Certainly in my opinion, once this process is embedded within practices or across a bigger area, it can really change the whole ethos of a practice, and certainly we would never go back to the old way of working. But it is a huge change that does involve a lot of training and a lot of work across an area.
Becky, thank you very much indeed.
No problem.
Fantastic run through. And Becky, if I can just ask you the same question, which I asked Lisa, which is, so where did you start? You talk about you'd never go back, but there was a time when you're doing quite a different model. What did those very early days look like?
So the early days were basically acknowledging that multimorbidity, or really people with multiple long-term conditions, is something that is happening, that we had to do something, we had to change systems to make it work better for people. And secondly, the care and support planning, using the year of care approach, being a much more person-centered way of working, and then really bringing together those two things, which had been done by other practices, a practice in Newcastle that was really at the forefront of that. And we were lucky that at the time we also worked with the British Heart Foundation on their House of Care projects. That was a good kickstart across the CCG. But at a sort of at a practice level, it's about training. and it's about getting the whole team on board. It's not something you can do just because one or two people think it's a good idea. You have to get buy-in from all the members of the team, and it's a whole practice approach, right down, you know, from admin to reception staff to the healthcare assistants and the doctors and the nurses. And it's a whole scale approach. And also, of course, the patients. In Gateshead, we've got a very active long-term condition and patient reference group who have just been instrumental to this piece of work and still are, and they input into all of the things that we do.
Lovely, Becky. Thank you very much indeed. Well, thank you, Amy. Thank you, Lisa. Thank you, Becky, for all of our presentations. One of the drawbacks of the webinar format is that it's a bit harder to do applause. But can I just give a round of applause wherever you are for our presenters? Thank you very much indeed. I hope everyone is applauding along at home. A really nice and very quick profiling of some of the different case studies and the overarching guidebook. We've got about 20 minutes for now for sort of a wider discussion, and we'll very quickly remind you of those ways, just in case you'd forgotten in the last 7 minutes how to do that. Ask question feature, email us hello@kscopehealth.org.uk, tweet using #multiple-solutions. Any one of those 3 ways, equally good. Send it through and we'll come to questions in just a second. And thank you very much indeed for people who've already been sending questions through. But before we go to questions, you'll remember when you signed up for this session, we asked you a question about some of the biggest challenges you face locally to improving care for people with multiple conditions. I've got a list here of 5 themes which came up, and so this is a game we can play along at home, but also for panelists, there are 5 themes here. What is on this list of themes, please? Becky, just because you're more person, it doesn't mean that you get to exempt. You have 5 themes. So we asked you, what are some of the biggest challenges you face locally to improving care for people with multiple conditions? What is on this list? There is a large hashtag for whoever gets closest. Becky, would you want to go?
I think finance will be up there quite highly.
Finance is on there, yes, thank you very much indeed. Budget constraints, tackling prevention and early intervention in a financially challenging climate. Tick. Well, 1 point to Becky. Congratulations, Lisa.
Accessibility.
Accessibility, well, I'm going to say yes. Awareness. Okay. Awareness is actually and accessibility came up here, and people just not knowing about the service even being there.
Yep.
We might come back to talk about in just a moment.
So I'd say probably something about the challenges of collaborative working or working across sectors or with different groups of people.
You're not allowed to look over my shoulder.
I didn't cheat. I didn't cheat.
Coordination, joined up working actually was the most frequently cited challenge when people were signing up around accessing records, taking a multidisciplinary approach among professionals, healthcare joining up with social care, lack of coordinated care to help people with multiple conditions who are socially isolated. Tick, 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 tick. We've got 2 more. Any last guesses for our last 2? So we've had coordination, awareness, funding.
Time, lack of time?
That's
GP.
Yeah, yes, well done, GP, waiting like a time. Well, the two which came through were primary care, actually, Becky, so we'll give you that one. So working with primary care to understand the potential contributions of social care and BCSE organisations to improving outcomes, engagement with GPs to raise awareness, engaging GPs to help people with dementia become more physically active. And then the last thing, there's a few comments around sort of community services and workforce, and make sure that community services are in the right place. I can well imagine that if you're sitting there at home, there's probably lots of nodding going along. I think probably those things resonate with a lot of people. Part of the point of the guidebook, Amy, is to show that these issues they're both everywhere, but also people have managed to overcome them successfully.
Yeah, exactly. That was definitely one of the aims, was to try and just give some really practical guidance on how some of these challenges have been overcome. But you know, it is really we've done 10 case studies, so it's really just a start. So we're really keen, the task force is really keen to learn from others and build on that, which is why it's great to have people on the webinar sending in some of their their examples as well.
Lovely, Amy, thank you very much indeed, and thank you indeed for people who are sending in examples. Going back to our question around techniques for change earlier, one instance being saying working with grassroots sports clubs to help them become more inclusive and therefore become health assets for their local communities. Is that going to tick, Amy?
Yeah, definitely. And actually one of the case studies in Luton was very much around physical activity and exercise trainers, and how they were the real linchpin of bringing about a whole new way of working across health and care and with the voluntary sector. So yeah, so that sounds like a really sensible approach.
And links there to the Richmond Group's wider work with Sport England around links between physical activity and healthcare. So please do have a look at that. A question I might pass over to you, Becky, if that's okay. Question from Dan. Dan, thank you very much. So Becky, you touched on this very holistic approach to your reviews. Dan asking, can you touch upon the way you might build in learning disability, autism, mental health safeguarding and capacity considerations, and how that works with parents and carers? Are there issues which I imagine do come through in your reviews?
Yeah, I mean, that's a very wide question, but it is an issue, and although the approach does fit with all of those conditions, it does need to be adapted. And there is sort of separate work going on for people with learning disabilities to try and adapt some of the paperwork especially. But what we find is even, and again, we're doing work on dementia to try and adapt some of the paperwork especially for those people. But what we find is with this approach compared to the old approach, even sharing information that perhaps that person couldn't fully understand or take in, because often their carers can, it can lead to really helpful conversations with carers, or often carers, whether it be family or other carers, can explain to the person a bit more before they come and see us, you know, what results are and what they might want to talk about. But certainly, especially for people with dementia, we are still using this approach and finding it very, very helpful at sort of pulling the whole family together, really.
Lovely. Thank you. Amy?
No, I was just going to say as well, actually, one of the case studies that's in the guidebook, which is based in the Southwest, is specifically with people with learning disabilities, and the approach that they took there was very much working with family and carers. So there's some, and they've got some quite practical tools that they used, which are all mentioned in there, and you know, sort of language and different ways of doing that. So there's stuff there to look at if people are interested in that.
Lovely. We haven't deliberately planned these questions just to plug additional case studies. Working out in that way. Lisa, I wonder if I could come to you, both in terms of that element, in terms of learning disabilities, but another question from Marceline. Marceline, I'm very sorry if I've mispronounced your name. Marceline saying, I'd welcome perspectives on how we can look at patient pathways and not at specialty pathways to overcome the siloed ways of working that comes with multiple conditions, and particularly keen on perspectives related to secondary care outpatient services. So if you're being really sort of cruel and cynical, Lucy, you'd say, great, you've created groups for one bit of a person's care, not the whole thing. I'm imagining it's probably not like that.
No, I mean, the people that attend our groups do have, you know, other things going on. I think it was mentioned earlier around, you know, people, the age group that we're working with, particularly over the 65 years, you know, do have many things going on. So what we have found with our local planning groups is that we have a wider audience there, and wider range of health services that can input into them. We have a lot of people who sit on our groups that are patient participation group members as well, you know, so are aware of other services, and you know, they can get away with shouting a lot louder and a lot of other things that we possibly couldn't get away with. So you know, one of the things around going to the groups is that it gives them that confidence to ask and speak up, and, you know, can be pointed in different directions. The speakers that attend the monthly meetings, some are very, very closely linked to respiratory healthcare, others a bit wider, you know, so there's falls teams, there's mental health and wellbeing, you know, so there is that broader perspective, and, you know, there's always that signposting element to the services.
Lisa, thank you very much indeed. Questions coming thick and fast. Please do continue to send them through. And a reminder that we are recording today. You can watch it back. You can continue to share sort of questions and observations using Twitter following today. So if we don't manage to get to everyone's questions today, please do make sure you have a look at the guidebook, and we'll try and respond via Twitter to any questions we don't reach. Another question for Becky, if this is okay, Becky. Emmanuel, thank you for joining, Emmanuel. Saying, Becky, it must take a lot of effort to organise this whole system approach. This is where you say, oh, that's really easy, Becky. A specific question, have you got a fit-for-purpose IT system at your surgery?
Yeah, yes, and it is a lot of effort. You can't underestimate the implementation stage of this. We've been very lucky. We have got a good IT setup. So within across Gateshead, we use a certain computer system, and all practices use the same one in Gateshead. In Newcastle, which is also part of our CCG, they have another system as well, which makes it slightly more complex. I'm lucky that in my practice I also have the IT lead for the CCG, so I very heavily relied on him, and we have an excellent template which helps us gather all the information we need and fill out the right things and have the recall lists to call patients in when they're due. So certainly the IT is invaluable behind the scenes at making sure that we have the recall registers, that we get people in when they're due, and also that we do the things that we need to do, tick the right boxes and check the medication, and all of those things need that IT behind them. So yes, we have got that. But again, it wasn't easy. It was all part of the setup phase.
So it sounds like your top tip there is to capture your CCG IT lead and trap them in your practice, Becky. Is that what you're saying?
They are your best friend, definitely, yeah.
Amy, we'll come to you. You may want to comment on importance of good IT to support some of these systems, but also a question from Hannah. Hannah, thank you very much for joining, saying, any examples of multi-morbidity models in secondary care settings and specialties working together?
Yeah, so in the guidebook, one of the case studies is in South Somerset, and that started from Yeovil District Hospital. It works with primary care in the area, but they have complex care units, I think in 3 places now in South Somerset, but it started in Yeovil, and they've come at it through that angle. So you can look at that case study. I have to be completely honest, there were probably others in my 45 long list, but I can't remember them off the top of my head. But the 45 long list of case studies is on the website as well, and there should be links for further information in there. So do feel free to go and have a look there as well. There was another example in Gloucestershire in the guidebook that wasn't sort of an acute setting, but it was community services based. So the community matrons led the work there with multiple conditions and linked in with other specialties and other services from that angle. So that might be another example that you might find interesting to look at.
Lovely, and clear links from this work, Amy, to the Richmond Group's previous work in Somerset.
Yes, of course. So yes, so we did some work with the Richmond Group of Charities and the Somerset sort of health and care leadership team to try and build collaborative working and find really practical ways of doing that. And social prescribing was one of the main focuses of work, but also other areas that were looked at were delayed transfers of care, which obviously is very much more an acute setting. So there's learning from that as well, also on the Richmond Group website if you're interested.
Amy, thank you very much indeed. Basically, if you've got any questions about anything, just go to the Richmond Group website. I'm sure they'll be able to help you. Lisa, we'll come to you for the next question, if that's okay.
Yep.
So Jade has been in touch saying, what are the main barriers which community organisations face when they partner with CCGs in order to scale integrated care? Whilst you're just thinking about that, Lisa, we are getting close now to the end of our time, and so just while we're sort of coming towards the end, a question for you to consider at home is sort of, if you are grappling with lots of these issues, how could the multiple conditions task force help you? And if you've got particular requests, there's no time like the present, so do please email those to richmondgroup@macmillan.org.uk. There we are, it's flashed up on the screen, and we'll just keep that on the screen now for the rest of today's webinar, just so even if it's the 30-second email, but what ways could the task force help you deliver sort of excellent multiple conditions care? We'll keep that up. Lisa, we'll come back to you. Community organisations, what are the main barriers they face when they partner with CCGs in order to scale integrated care?
I think from our experience, one of the things that we found is that CCGs have so many priorities, and working in quite a specific field, we obviously have respiratory care as our ultimate #1 priority. So it's trying to battle against other commitments that CCGs have. From our perspective as well, there's quite a lot of bureaucracy, and their timeframes don't necessarily marry with ours. So I think one of the things that we say is just keep on going and pushing. And as we said, we've got an amazing array of patient volunteers that run the groups who can maybe shout a little bit louder in different forums and in delivering different messages than we can. So it's just keep on pushing forwards really as best you can, and you know, fighting for respiratory to be up there.
Lovely, Lisa, thank you very much. I realise I've just gone CCGs without any explanation, so I'm going to put some here. And of course, well, not of course at all. Clinical commission groups, CCGs. Apologies for that. We've got about 5 minutes or so left. There are questions still coming through. We're going to, Amy, a very quick one from Gillian. Are you planning to present these at any conferences with medical papers? I'd love to see this shared and replicated elsewhere. Let's take that into a more general next steps. How else is the guidebook getting out there to the people who need it?
So it's already been presented at a couple of conferences. So at the King's Fund, there was an event on multiple conditions. And then we've got this webinar, and I think really actually one of the questions that, as you've just said, we had is actually where would it be helpful to see this, and also can we help you to go out and present the material, because you know that's sort of how we can really spread it and spread the message a bit more, is to get other people to do it as well. So we'd be really keen to know exactly where people would find it to be helpful to be done. I should say as well, the task force itself has an expert advisory group with lots of great and good people on it, who will all be out there and talking about it and doing that from that side of point of view as well. So
lovely. Thank you very much indeed. We're very fast running out of time, so we're going to do very quick reflections, final reflections from our panel. Where I'm afraid you'll have about 24 seconds each to give one quick reflection. I will go first to buy you time, and then we'll go Becky, then Lisa, and Amy will get the last word. But again, just to say thank you so much for joining. That email address is still up there. We'd love to hear from you about how the task force could help you. Please, 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 don't put it off until Monday. You'll forget about it. Just spend a couple of minutes, if at all you can, just thinking about how the task force could help you. Would really appreciate it. So final closing reflections. One quick one from me, quote from you, Becky, actually saying, you can't do this stuff just because one or two people think it's a good idea. There's so much here which we sort of think, oh yeah, lovely, well, of course everyone should do that. But it sounds like in both of your examples, you've really put in the hard work to make sure that there was real shared ownership of these ideas, which was going to sustain rather than just peter out. So there's hard work, but how you get that shared ownership appears key. Becky.
For me, it's just the fact that, you know, people are living with long-term conditions from a younger age, with more conditions, and we have to proactively change our systems, change training in order to support people to live well with their conditions, and we need to make changes now.
Becky, thank you. Lisa.
I think mine would be that one size doesn't fit all, and even though we've got people living with the same conditions, the support and the experience is quite different, and we need to be aware of that when we're looking at services, you know, to help those people moving forwards.
Lovely. Amy.
I might have a couple of things.
Oh, all right. No, well behaved.
Extra
one of them's a bit repetitive, probably.
Okay.
But I think, yeah, one of my finds is that I think there's a huge strength that comes a lot across in a lot of these case studies, where people are working together from across primary care, the voluntary sector, hospitals, people themselves in communities. And I think that's the sort of key thing that I take away from all of this, that if we can actually all just work together and in sensible ways, because we're all trying to do the same thing, and actually is to help improve the lives of people, then I think, you know, we can make really good progress. And, you know, as I said, this is probably going to be a bit repetitive, but the task force really does see this work as a two-way process. There's 10 case studies here. It's just a start. You know, they would really love to build on this. So, you know, please do share back with us positive and negative thoughts and feedback, and please do share with others. You know, yeah, so really keen to encourage a sort of discussion and a wider community discussion about all of it.
Lovely. Amy, Lisa, Becky, thank you very much indeed. Thank you again, everyone, for joining. So in terms of next steps, we've been recording today. You'll receive an email later on with the links to the recording. Please do share it with all of your family and friends, as well as your colleagues who may well be interested in this. If we've received further questions which we haven't been able to answer, we'll answer all of those on Twitter following today's session. The Multiple Conditions Guidebook, if you're yet to find your copy, probably the quickest way, just Google Multiple Conditions Guidebook and up it will pop. We would very much recommend doing it. And finally, once more, we would really like your suggestions as to how the task force can help you. That email address, once more, is on your screen, richmondgroup@macmillan.org.uk. Please send those through. If you've got a minute just now, that would be great if you could do that, because that really will influence the work of the task force going forward. Thank you very much for joining. Thank you again to our presenters and panelists, and we hope to see you again at a future webinar. Goodbye.